Welcome, welcome, welcome to the second virtual COPIC event for Rocky Mountain Cancer Center. I'll say this at the beginning, COVID has been a new format for everyone, and we're figuring out how to do this Zoom, but as we zero in, we think it'll be a good experience for everyone. So we do hope that you'll find this update on lung cancer screening and treatment to be beneficial. I am Dr. Dennis Carter, a radiation oncologist at the Rocky Mountain Cancer Center, Aurora location. I'll be moderating today with four of my medical oncology colleagues. That's Dr. Robert Joddy at Skyridge, Dr. Hussein Mamani at Longmont, Dr. Tim Murphy from Colorado Springs, and Dr. Doug Resnick from Aurora, Centennial, Littleton, and Swedish. Our attendees will be muted throughout the presentation. However, we hope you will participate through conversation and questions in the chat feature, and we will be monitoring the chat throughout the presentation. Your attendance is being recorded and will be reported to COPIC, and thank you for taking the time to join us. The five of us have worked together to come up with topics that we think would be most interesting and beneficial to you, the listeners, and especially from a primary care perspective or a general perspective. And what we've come up with is we're going to talk about the changing incidence and mortality related to lung cancer, the screening and diagnostic workup of lung cancer. We're going to discuss the major changes that have come out in treatment through radiation oncology, chemotherapy, immunotherapy, and biologics. We're going to talk about how some of these new treatments have altered how we manage toxicity and how that might specifically impact your individual offices. And we're going to discuss what we think might be coming in the future through some of our promising trials. The first topic then today we're going to be discussing is cancer incidence and mortality rate. And so for this, we're going to turn to Dr. Joddy. And I'll start by saying, because lung cancer is both common and deadly, it has long been the leading cancer cause of death. And so, Dr. Joddy, what can you tell us about the lung cancer incidence and mortality rates in the United States?
Thanks, Dennis. So, one of the first pieces that I always try and stress, particularly in the primary care setting, has a lot to do with the changes that have come over the course of the last two and really almost 5 decades now. There's been a tremendous acceleration actually in the last 10 years in terms of mortality, and I'll get to that in just a moment. But if you look at the historical progress that we've made, it's been slow up until about the last 5 years or so. But I would say fairly 20 to 30 years ago, there was a fairly nihilistic approach to diagnosis of lung cancer. And it was very common that oftentimes patients elected to not do anything. And now that has dramatically changed. If you look at the incidence, just in terms of the United States alone, there's about 250,000 patients, just under that, that are diagnosed with lung cancer and projected to have been diagnosed with lung cancer this past year. And it's about half and half. Still a slight more predominance of men than women that are diagnosed with lung cancer. But definitely, and sadly, women really caught up to men as the acceptance of tobacco use for the different genders really increased quite a bit over the last century. But it still remains primarily a disease of our older patient population. If you look at most patients are going to be diagnosed after the age of 65. The average is actually about 70 years old. And it says, as Dr. Carter alluded to, it still remains the leading cause of cancer death for both men and women. In fact, if you compile and sum the total patients that die from colon, breast, and prostate cancers together, lung cancer still beats out the total of those 3 different cancers. But on a positive note, the incidence of lung cancer does continue to decrease. And a lot of that has to do with quitting smoking and early detection, which Dr. Resnick will be getting into shortly. So incidence has gradually been improving, and also over the last decade has taken a leap in that, primarily, again, related to earlier detection and the tobacco cessation programs that are now readily available. As far as mortality is concerned, that too is something that gradually has been improving. If you go back and you look back to the 90s when platinum was one of the first drugs approved for lung cancer, it improved survival by a little bit. And for that reason, a lot of patients elected maybe to not do chemotherapy. But the reason it was primarily approved at the time was that it actually improved patients' quality of life. So it wasn't the substantial improvement in survival, it was the improvement in quality of life that led to chemotherapy becoming something that was offered to patients diagnosed with lung cancer. And we gradually made improvements over the last 2 decades with newer drugs such as paclitaxel, so some of the taxanes that got introduced. And then we started getting into some of the more targeted agents, drugs such as bevacizumab that targets vascular endothelial growth factor. And then we started finding new targets such as tyrosine kinases that would be turned on. And you could give patients an oral pill to actually target those abnormalities in patients' lung cancer. And then most recently, we've stumbled upon this whole concept of immunotherapy. And Dr. Murphy will talk a little bit about that, but some of the toxicities that come with that. But immunotherapy has literally changed the landscape of lung cancer treatments tremendously. And the reason for that is because of its high tolerability and the fact that patients have very good durations of responses. In fact, if you look at patients that historically would have been told with a stage 4 lung cancer, you've got, maybe 5%, probably less than a 5% chance of being alive at 5 years. If you take a good portion of the population that has high expression of PD-L1 in their tumor cells, the most recent updates that we've seen, some of those original trials with immunotherapy, 25% of those people are alive 5 years out. And they're continuing on their immunotherapy, but, so they're remaining on therapy, but a very highly tolerated IV treatment that are keeping our stage 4 lung cancer patients alive for a much longer period of time than we ever imagined. And I think we're finally realizing in our own lifetimes some of the hopes that we had 20, 30 years ago for patients diagnosed with this diagnosis. So that's kind of where we stand now, Dr. Carter, and we've definitely made advances, and it's not the nihilistic, deadly diagnosis that it once was.
Thank you, Dr. Joddy, and we'll be talking to you again about trials later. So this has been really amazing in our world for so long. Lung cancer has been stagnant in terms of the outcomes. We've all experienced the dismay that comes with the lung cancer diagnosis, but this long-term survival throughout the country is now some evidence suggesting it's doubling compared to what it was just 10 years ago. So a big part of this is the diagnosis changes. So it's really diagnosis and treatment. And so to Dr. Resnick, Dr. Joddy alluded to a little bit the importance of early diagnosis. How do we achieve early diagnosis?
Right. So there's many patients that will present with no symptoms at all. So some of the common symptoms that we certainly need to acknowledge, some of the more common ones that can lead to a lung cancer diagnosis is a cough. Cough is probably the most common symptom a patient could present with. But keep in mind, many things can cause a cough. So look at their risk factors. Unfortunately, not everyone who gets lung cancer was a smoker. About 90% of males who are diagnosed with lung cancer are smokers, but 70% of women who are diagnosed with lung cancer are smokers. So there's a percentage there that acquire that diagnosis for non-tobacco related reasons, which are not really included in the screening guidelines. But in terms of symptomatology, cough would probably be the most common symptom. Patients can often have hemoptysis, so they can cough up blood, they can have chest pain, they can have shortness of breath, they can have hoarseness, they can lose weight, they may present with recurring infections. So those are the symptoms to actually take into consideration and make you think of possible lung cancer in the differential. In terms of screening, lung cancer is actually the 5th cancer that now has national screening guidelines in place, which is quite remarkable if you think about the abundance of cancers that are present, and that we see the majority do not have standard screening guidelines, either in this country or other parts of the world. And for many years now, there have been clinical trials published looking at different forms of screening for lung cancer. They looked at chest x-rays, they looked at sputum cytology, and none of those really made a difference. And what do I mean by making a difference? Well, when a screening trial is implemented, it needs to demonstrate a benefit. It needs to demonstrate not just a cost benefit, but most importantly, a survival benefit. So by screening these individuals who are at risk, it'll change the outcome. And that's been proven in breast cancer, colon, cervical, prostate. The guidelines for this disease is a little bit different, a little bit more stringent, and they do not apply to all. And back in 2013, in the New England Journal of Medicine, the National Lung Screening Trial was published. And this was a phase 3 study of over 50,000 individuals, okay, who met certain risk criteria. And they were randomized to receive a low-dose CT scan of their chest or a standard chest x-ray. And patients needed to meet the following eligibility criteria. They had to be between the ages of 55 and 80. They had to have at least a 30-pack year history of tobacco use. And they had to be either current smokers or had smoked within the preceding 15 years. And most importantly, they had to be asymptomatic. They couldn't have had any of the symptoms I had alluded to earlier, because that would put them in a different category altogether. It wouldn't be a true screening. And these patients were screened until they no longer smoked for up to 15 years, or they developed health problems that may impact their life expectancy, okay? So the benefit, and I'll give you the bottom line because there's a lot of details to the trial, but if you want to read about it, it's published in the New England Journal of Medicine. I believe it was in 2011. So the benefit was, in terms of mortality, there was a 20% reduction in mortality from lung cancer, okay? And they needed to screen approximately 320 patients in order to prevent one lung cancer death over 10 years. So the benefits are great. You know, this is the first positive study, and based on the positive results, the United States Preventative Task Force recommended it, and that started in 2013. In spite of those recommendations, it's unfortunately still highly underutilized, like a lot of other screening measures, colonoscopy, for example, where maybe 35% of patients are getting screening colonoscopies. Well, here, as of a few years ago, it was in the range of less than 5%. And there's reasons for that. And probably for the purpose of today, we don't have time to really get into that. But keep in mind too, when you do such trials like this, you also have to think about the potential risk and the false positives that may get diagnosed when you're doing these scans. So sometimes if you have a false positive nodule that's detected, there could be unnecessary testing. You know, there's invasive procedures that can lead to complications. There's additional costs. There's the anxiety, etc. I think for the sake of time, I'll stop there and leave you all with one final point, in that there was a very well done screening trial called the Nelson trial. That was done in Europe. It was done in the Netherlands as well as Belgium. And you can actually read the latest publication in the New England Journal of Medicine from earlier this year. The design was different, But the bottom line is it's supported screening. Based on the results of the Nelson trial, the task force is actually looking to modify screening guidelines, and this is currently in play. And so they're trying to broaden the criteria of those that would be eligible to get screened. They want to lower the age to 50. They want to lower the number of pack years to 20. Interestingly, the number of pack years in the Nelson trial was just under 40 versus it was just over 50 in the US trial. And they also want to take into consideration some other threshold criteria to improve early detection and survival and make it more inclusive for certain populations that are at a really high risk that don't quite meet their criteria. You know, and Dr. Joddy mentioned women, and I think they're at an unfair advantage because there's, women much more than men who've never smoked are unfortunately at a greater risk and mercy to this disease than men, as well as African Americans who have been way under tested or screened than the Caucasians, and they also pose a much greater risk than the Caucasian population as well. So I think I'll stop there and turn it back to you, Dr. Carter.
All right, thank you. So screening really has changed the landscape of how we find lung cancer. And as I'll point out next, it does make a big difference in our treatments, and it's underutilized. So this is a very important thing for people to think about in the primary care setting in particular. So our next topic is the advances in radiation oncology. So radiation oncologists such as myself have been enthused by the technical advances in our field. Increased precision through imaging, advanced treatment planning techniques such as intensity modulated radiation therapy and volume modulated arc therapy, where we're able to manipulate the dose and how it's administered much better. Non-surgical ablation such as stereotactic radiosurgery and stereotactic body radiotherapy. These are ways to administer an ablative dose of radiation to the patient without a surgical approach. All these fancy technical advances really only make a clinical difference because of the combined advances from other disciplines in medicine that we work with this. For example, I have a graph here that shows that stereotactic body radiotherapy for early stage lesions, we're getting remarkable results. Historically, 10 or 20 years ago, we were getting a 30% local control rates, 30% overall survival. This is now improved to a 90% local control rates and survivals that are comparable to what we're seeing with surgery in similarly selected patients. And so we are seeing now the emergence of randomized trials where people starting to investigate and ask the questions, could non-invasive approaches to treating small lung nodules be just as good as open thoracic surgeries? And for many of our patients, this is required anyway because they're long-term smokers, they have terrible lungs and other medical problems, so they can't really get the surgery. And for those people, for sure, a benefit. But all this benefit is only really achieved if we're able to get an early diagnosis. And it's the combination of an early diagnosis with some of these advances that we're seeing good outcomes with low benefit or low injury. Another thing is the advances in systemic therapy really only is what causes a clinical significance in local control. So when we get improved radiation therapy for local control or improved surgical techniques for local control, this only impacts survival if we can see an improvement in systemic control. So when over the last 40 years, clinicians have often assumed that the improvements in systemic therapy might make local control no longer necessary. So maybe we don't need surgery or radiation or something like that. But the opposite is actually true. It's only with the improved systemic control that we're able to make a meaningful difference with the improvement of local control. So as we control systemic disease with improved systemic therapies, then local therapy makes more of a difference. And so we have seen this in small cell lung cancer, we've seen it in breast cancer, we've seen it in oligometastases and several other types of situations. And I'll just highlight an example, oligometastases, even in the setting of, oh, there we go, the second one. So in our second slide, the other slide, this is in the setting of limited metastatic disease. With improved systemic control, we're starting to see improvements in survival by treating distant metastatic disease. But this is only really meaningful if we're able to achieve early findings of metastatic disease with diagnosis and good systemic control, including the use of effective systemic therapy. So it's the combination of these advanced radiation techniques with improvements in other disciplines that we really are beginning to see a difference. And so that leads into our next topic, which is chemotherapy and immunotherapy. So one of the major advances in terms of systemic control has been how do we achieve this improvement in systemic control? And that's largely come with the addition of immunotherapy. So Dr. Memani, systemic therapy is no longer limited to just cytotoxic chemotherapy. And so what are our options for systemic therapy now?
Thank you, Dennis. You're absolutely right. In 2020, talking about the intricacies of chemotherapy has kind of come and gone. And a lot of patients are interested in immunotherapy for good reason. And it's not just lung cancer, immunotherapy and the concept applies to almost every malignancy at this point. And immunotherapy has been around for quite some time. We were using BCG for bladder cancer and interferon for melanoma. But now we have immune checkpoint inhibitors. So when we talk about immunotherapy, we're really referring to immune checkpoint blockade. And the best way for me to kind of explain the basics of that is to share a quick PowerPoint. I'm going to share my screen here. So on your normal cells, you express a cell surface antigen called PD-L1. And this PD-L1 tells your T cell, hey, I'm one of the good guys, leave me alone. And if you underexpress PD-L1, for example, in certain autoimmune conditions, your T cell can recognize your own cells as foreign, and you develop autoimmune conditions thereafter. Tumor cells can get smart. They can hyperexpress this PD-L1 on the surface of a cancer cell. And when the T cell comes in, it cannot recognize that cancer cell, and then it moves on. And so that's one mechanism that cancer cells use to thwart the immune system. And the concept here is fairly simple. What if we remove PD-L1 on the cancer cell? Or what if we block PD-1, which is what interacts with PD-1 on that T cell? And by blocking that, the idea is the T cell comes in, recognizes the cancer, brings in the cavalry, so to speak, and the rest of the immune system comes in and gets rid of the tumor. So these PD-1 and PD-1 inhibitors, they've been around for quite some time. For the last 5 years, they've been FDA approved for non-small cell lung cancer. So you might have seen commercials of Opdivo, Keytruda, as well as other immune checkpoint inhibitors, Atezo, Durva, and ipilimumab. But the real interesting, the real interest with immunotherapy is the long-term survival. So this was the first study done in patients with non-small cell lung cancer treated with Opdivo versus chemotherapy. The median progression-free survival, and this is where it gets tricky, for Opdivo after chemotherapy was 2 months. And that's not quite impressive. But the issue is with lung cancer, it's not a story of the medians. So when you look at the tail end of the curve, what you find is that there is a small percentage of patients that appear to be responding to immunotherapy, and that response continues for quite some time. So this tail end of the curve is very important. And that tail end of the curve occurs in a whole variety of other tumors. So we saw it with melanoma initially that, hey, look, if you're out 2 to 3 years treated on immunotherapy, and bear in mind, a lot of these patients only got treatment for about 2 years. If you're beyond 2 to 3 years and have no evidence of tumor, that response appears to continue. And that occurs with melanoma, RCC, and other immunogenic tumors, including non-small cell lung cancer. So as Dr. Joddy had alluded to earlier, we have patients that have been treated with these immune checkpoint inhibitors, including Keytruda, for example, that have had success long-term. So some of that depends on PD-L1. So remember back to that initial diagram. If you have a lot of PD-L1, if we can target it, you probably will have a better response. So patients that have expression of greater than 50% generally do fairly well with immunotherapy, and we have greater than 5-year follow-up, and almost 50% of those patients are still doing pretty well this far out. But even patients that don't have strong expression of PD-L1, around a little less than 20% of them still are doing all right, and still, if they're able to get out to that 2 to 3 year mark, we don't see that they're recurring. So is it a cure? I don't usually use that term in clinic. Typically, we talk about long-term response, but certainly, maybe in this decade, we'll have more follow-up, and maybe some of these patients don't recur. In the melanoma studies, which were done before non-small cell lung cancer, those patients don't appear to be recurring, and you have patients out 10 years on those studies. But I think immunotherapy is exciting. I mean, we've been using immunotherapy for half a decade now, standard of care, but Dr. Joddy is really going to focus on clinical trials, and I think this is where the excitement is. This immune checkpoint is only one small piece of the immune cascade. This interaction between PD-1 and PD-L1 on the far left is only one piece of it. We've been able to also manipulate CTLA-4 with a medication called ipilimumab, but there's a whole variety of other checkpoints that we have that we're looking at trying to combine immunotherapies, combine chemotherapy. We're also looking at Dr. Carter adding radiotherapy. If we add radiation, can we try to change the immune response? Can we manipulate the immune response? So really combination therapies for lung cancer as far as immunotherapy is really the future. But as it stands right now in 2020, we're still having great success with a small percentage of patients. And with that, I will throw it back over to you, Dr. Carter.
Thank you. Immunotherapy really has changed things. And historically in the oncology world, it seems like when we reach a barrier in terms of how much improvement we can get, it's really associated with we're maxing out the toxicity, what we can achieve, and really advances, changes in our systemic therapy. A big paradigm shift is associated with new side effects. It's almost like we've maxed out the side effects from the previous therapy. And we're all kind of accustomed to the side effects of chemotherapy, but the immunotherapy has a new set of side effects. And so my question to Dr. Murphy is, how are the side effects from immunotherapy different from what we're used to? And also maybe pertinent to our audience is, how can other physicians outside of oncology help us in management of these patients?
Super. Thanks, Dennis. I really appreciate it. And thank you all on the call for giving me an opportunity to highlight what really has become a dramatically changed landscape in the management of side effects for our oncology patients. As we shift away from cytotoxic chemotherapy, we all know the widely recognized effects there: nausea, vomiting, fevers, neutropenia, hair loss. I presume everyone on this virtual meeting has had some training and probable real world experience helping us manage those types of side effects. But as we rapidly incorporate these immunotherapeutics, the side effect landscape has dramatically changed. In fact, we're seeing side effects that frankly, we never really had to focus on during training or fellowship. And it's those types of side effects that I'd like to focus today on. Immunotherapeutics in general have a reported side effect rate of upwards of 75% of patients who get these report some side effects. In general, they can start within 2 to 4 weeks of initiating the therapy. And possibly most important for this audience, these side effects can arise up to 2 years after treatment has been completed for patients. So it would not be unheard of for a primary care doc to encounter a patient years after their cancer therapy with some kind of weird symptoms that ultimately might be tied back to their immunotherapy exposure. If I had to summarize what the overall side effect profile of immunotherapeutics are, I would say this: pick an organ system and add itis at the end of it, okay? It's inflammation. As Dr. Maimani had kind of highlighted, what we're doing is we're unleashing the immune response. So any organ system is up for grabs on a toxicity. Two takeaways. The other takeaway on this is my iPhone address book is bigger than it's ever been. So on speed dial, I have a dermatologist locally, a gastroenterologist, a pulmonologist, an endocrinologist, a cardiologist, a rheumatologist, a neurologist, and an ophthalmologist. And in the last 5 years, I have called every one of those specialties regarding toxicities of my patients. So in general, we grade an oncology toxicity on a grading profile of a 4-point grade, 1 through 4. A grade 1 toxicity is kind of a mild, annoying. We don't stop therapy. We typically give over-the-counter medication. Grade 4 toxicity is life-threatening. Patients in the hospital, we're getting multiple subspecialists involved. And although 75% of patients develop toxicity, fortunately, the vast majority are in the grade 1 and 2. So these are side effects that are managed as an outpatient. They easily can present to a primary care doctor for management. Once you start getting into the grade 3s and 4s, we're in the hospital with multiple consultants going on, but that's 5% or less of all toxicity. However, to Dr. Maimani's point, we're starting to combine these drugs, and what we have seen in some data, if you combine these different pathway blockers, severe toxicity goes up. Rates can be reported in the 10 to 15% grade 3 or 4 toxicity range. So this is becoming very tricky to manage. That's the overall. I'll give you the quick, I've got a little bit of time. I'll just start on prevalence. The most prevalent side effect is dermatologic, maculopapular rash, pruritus. Again, as you can imagine, those are managed with very simple over-the-counter medicines, topical steroid cream. You can get into the bullous disease though, the more Stevens-Johnson's. That's obviously a grade 4 toxicity. Second most common reported would be gastrointestinal. Diarrhea, again, grade 1 through 4. Treatment is, most of these side effects is steroids, okay? Prednisone, 1 milligram per kilogram per day. When they're in the little more than grade 1 scheme, if they're grade 2 or above, essentially all of these side effects are first-line treatment is stop therapy and put on prednisone, 1 milligram per kilogram per day, and then start calling your consultants to help and manage, because it can go from diarrhea, it can go the endocrinopathies, it can go from the pituitary through the thyroid, adrenal gland crisis, type 1 diabetes. I've personally seen my patient develop in her 50s as a result of exposure to these medicines. Pulmonary pneumonitis manifested by cough, shortness of breath, drop in oxygen. Ocular side effects fairly underreported, but very prevalent. So ophthalmology consults are quite common. And then go through the neurology, myasthenia gravis, Guillain-Barré type symptoms. Fortunately, thank God those are rare. And then through the rheumatologic, the inflammatory arthritides, myositis. They're all the same pathophysiology. It's an enhanced immune response. Treatment is to lower the immunity with immune response with prednisone. We can up the ante with things like rituximab or infliximab or Cellcept. But once you're talking those drugs, that patient's generally in the hospital with multiple consultants. So these are different side effect profiles. Some of them sound scary, but again, the vast majority are grade 1 and can be managed by in the primary care setting. All right, with that, Dennis, back to you.
Thank you, Dr. Murphy. So this is interesting. We've had big advances in the outcomes, long-term survival in lung cancer patients. Most people get through it pretty well. Some have bigger and more serious issues. But parallel to this enthusiastic approach to immunotherapy has been another option, and this is directed to Dr. Resnick. We have biologics, and maybe the terms biologics and targeted therapy have been used interchangeably. Dr. Resnick, what can you tell us about how biologics are changing treatment of lung cancer and the side effects of biologics? And that's not Dr. Resnick. Dr. Resnick will be coming to us shortly.
There we go. Can you hear me?
Yes, that's great. Thank you.
Okay. Yeah, and I think those terms, Dennis, are used interchangeably as far as biologics and targeted therapy. Biologics, it certainly implies that the drug is manufactured or created, from a live organism, whether it's human, animals, other microorganisms. And there are such targeted therapies that fall under that category, but not all targeted therapies, especially most of those that we use in lung cancer, I would consider biologics. Most of the targeted therapies we use are more like small molecules. We do have monoclonal antibodies as well, but I find the history interesting, because hormone therapy you can consider a targeted form of therapy, and probably the earliest form of targeted therapy we've been using goes back to the late 60s, early 70s, when tamoxifen first came into practice for hormone-sensitive breast cancers. And that's a drug that targets the estrogen and progesterone receptors, and that still is used in practice for many different indications in breast cancer. As far as the lung cancer targeted therapy armamentarium, the first drug that came into play really dates back to around 2003. And at the time, we weren't doing any specialized testing to help us understand, where these drugs fit in. And back then, there was really only one drug that got approved. It was a drug that specifically targeted the epidermal growth factor receptor, which is a cell surface receptor and is commonly mutated in lung cancers. It's one of the most common mutations we see in people with lung cancer, more commonly in the adenocarcinoma population, more commonly in people who don't versus do smoke, more commonly in females versus males, other ethnic populations. And that drug was approved in 2003 for really a later line of treatment. We were still pretty much using chemotherapy. That was the standard. And back then we understood the drug, but we weren't quite testing to see if someone had a mutation on their for the EGFR receptor. And we came to find out that, and so we were essentially using it in an unselected population of patients. And a percentage of patients responded to it. They felt well, their scans looked better. And interestingly, and the reason why I'm sharing this story is because there's probably upward of 50 to 60 patients worldwide that are still on that original drug who back in '03 presented with widely metastatic lung cancer. Okay, so there's a percentage of people where it significantly changed the natural history of their disease. It turned a terminal illness into a chronic disease. Well, unfortunately, that's not the case with most of the targeted therapies. As you heard with the immunotherapy, you can have these durable remissions long after immunotherapy is stopped. Fortunately, with the targeted therapies, mutations are bound to develop. People actually acquire mutations in response to these drugs. And if you were to stop the drug, the patient's cancer would progress. So as far as the lung cancer targeted therapy drugs, when a patient is diagnosed with advanced lung cancer, really it applies mainly to the stage 4 population. When they are diagnosed, it's a category 1 guideline now through the National Comprehensive Cancer Network that all patients get tested to see if they have any mutations. And you can have sensitizing mutations, you can have these gene rearrangements, but we've got over a half a dozen now that are standard that have FDA approved drugs that target some of these mutations if they're present. So these drugs, most of them are given orally, so they're convenient. And when you look at their efficacy in terms of their responses, their duration of response, in some folks, they're upward of 2 to 3 times longer than with immunotherapy or chemotherapy. And again, the responses and the duration of response really varies from one to the next. And the prevalence of any of these receptor mutations really varies from less than 1% to as high as 20 to 25%. And so that's very important when one is diagnosed that we test, because if a genetic mutation is present, we would start their treatment, providing there's no contraindications, with a targeted drug. That would trump immunotherapy and chemotherapy. And as Dr. Murphy mentioned, there's ongoing trials looking at various combinations with other categories of treatment. And the convenience is there because patients can administer these at home. They can carry on with their life. They're not held hostage to having to come into, the infusion suite and sit for a period of time and get an IV infusion. The side effect profile of most of these is much more attractive than chemotherapy, for example. If you think about chemotherapy, it's cytotoxic. I like to think of, when we compare the side effects of targeted therapies to chemotherapy, it's like fighting a war. And I often tell my patients, chemotherapy is like carpet bombing. It kills the good, the bad, and the ugly. And you hopefully the bad cells stay down, the good ones recover. Where the targeted therapy, it's more like smart bombs, and it's very selective as far as how it works. And its downstream pathway is very different than the mechanism of cytotoxic chemotherapy, for example. And the degree of side effects, again, depends on the drug. But I'd say in comparison to other forms or other categories of systemic therapy we use, most of them commonly can cause fatigue. Most of them can cause skin, GI side effects. It can affect the blood counts, generally not to the same degree that we see with some of the other drugs that we use. In some situations, Dr. Joddy mentioned bevacizumab, Avastin, which is a monoclonal antibody that targets a specific receptor and affects angiogenesis. So that drug could affect the vasculature. We could see blood clots with those. We could see hypertension, et cetera. So I think overall the targeted drugs have significantly shifted the survival curve to the right. I think much of why the overall survival, when you look at all stages of lung cancer, has improved. It is not just screening, but also because of the targeted drugs, the immunotherapy drugs, and then of course side effect profile much more attractive, and convenience. I guess we're running low on time, as I could tell by Dr. Carter's expressions. But the one thing I think that's just one last point that's important to mention is these drugs cross the blood-brain barrier extremely well. And it's variable. It's anywhere from 40, 50% to as high as upward of high 70s, 80%. And the reason why I mention this is because for many of these patients, the CNS is a sanctuary site. and the risk of CNS relapse is high. So when someone has the opportunity to use these drugs, this can significantly improve outcomes for that reason as well.
Thank you, Dr. Resnick. So we are getting short on time, and for all those who can stay for the conclusion, we just have 2 more sections, and that is we're going to talk about future trials with Dr. Jati, and we'll try to get through these as quick as possible. And then the last thing, we're going to do some quick take-home points and conclude. So, Dr. Jati, we've talked about immunotherapy, biologics. There's a lot happening in lung cancer right now. How many trials does Rocky Mountain Cancer Center actually have available to our patients? And what do you see as the promising, most promising trials going forward?
So thanks, Dennis. So, really a couple of things. One is at any given time, in any given moment, we'll have varying numbers of trials available. And many of the mechanisms by which some of the targeted therapies and immunotherapies and many immunologics that were alluded to by Drs. Resnick and Maimani is where a lot of those studies are directed. At any given time, we might have anywhere between 25 and 30 trials available. And so those trials that really are looking at specific targeted agents as well as immunotherapy agents is really where the greatest level of excitement lies right now. Dr. Resnick alluded to the number of patients that have mutations that are available to target. While all of them might be small numbers of targets, 1% here, 2% here, 3% here, they all tend to be independent of one another. In other words, if that's the pathway by which a normal lung cell became a cancer cell, that's probably how all of the cells are behaving, and it's unlikely they'd have another dual mutation occurring at the same time. So when you start to add up all of those different mutations, including things like EGFR and KRAS, which is a new topic of interest, you're starting to get on the upwards of about 75% of patients that have targetable mutations, and that's not even including those patients that have PD-L1 expression. So a lot of new trials that are coming out constantly. And I'll kind of finish up with really a plea to all of the attendees in our talk today, and that is, if your patients ask you about clinical trials, please encourage them to consider enrollment in a clinical trial for 2 reasons. One is, if you look at patients that get enrolled onto a randomized trial where one of the arms might be standards of care, those patients that actually just get the standard of care, which is what we would have administered to them had they gone on a clinical trial or not, patients that go on a clinical trial do a little bit better even in that control group, likely because of the level of surveillance that those patients undergo when they're on a clinical trial. Very heavy level of monitoring that goes on with those patients in terms of toxicity, labs, et cetera, by our research staff. And the other reason is because the only reason that we had anything to really talk about that sounded promising today is because of the gratitude that we all have in medicine for all those patients that made that leap of faith to go on a clinical trial, did so, and those patients that Dr. Resnick alluded to that back in the early 2000s elected to go on a clinical trial, they're still alive because of that. So I would very much encourage you to encourage your patients to consider a clinical protocol if they bring that topic up with you in your office. And with that, I'll turn it back over to Dennis because of the time we're running into.
Thank you, Bob. So I'll just summarize a few quick take-home points that you might want to remember to highlight. So the first one is survival in lung cancer has really improved dramatically, with some studies showing over a doubling of overall survival predicted now compared to just 10 years ago. And so when you have that dismay and discouragement that when you get a new lung cancer diagnosis, just don't let that translate to a nihilistic approach and really give these patients a chance. The second thing is annual low dose CT screening is a thing, and it does impact survival. And so for your smokers or previous smokers, really consider CT screening. The third thing is there are many advances throughout all the disciplines of radiation oncology involving chemotherapy, immunotherapy, and biologic that are radically changing our lung cancer treatments. And we do need participation from other specialties to help us figure out how to best manage these patients. And that highlights my last thing is a multidisciplinary approach is critical as we deal with these patients involving medical oncology, radiation oncology, surgery, radiology, pathology, pulmonology, primary care, and all the different specialties. Chances are that if you're on this call, you've heard your specialty mentioned through this, and we really do need you. So as the last final thing I'd like to say, I'd like to say an expression of gratitude for all of our experts who took time for their day to participate with us. Thank you for the participants who joined today and anybody who might be delayed listening on the recorded call. The live attendance has been recorded and will be submitted to COPIC for credit. And we welcome any feedback that we can get. You will send surveys out, and we would really, truly like to hear what we can do better and what has worked well for us. Hope everyone has a good rest of their day. Thank you.